Welcome to the deep dive. Sometimes we talk about illnesses that, well, they sound like they belong in a history book, don't they?
They really do.
But the thing is, they're often still very much around, and today we're going deep into one of those, scarlet fever. Now, if you're a parent or you work with children or frankly, you just want to be informed, getting a handle on this one is really quite important.
Absolutely. It might sound a bit old-fashioned, but knowing about scarlet fever, spotting it early, that helps avoid any potential problems down the line.
Exactly. So consider this your mission for today, getting a really clear, high-yield overview of scarlet fever. We've gone through the revision notes, picked out the key stuff for you.
Yep. Distilled the essentials.
Think of it as your fast track to feeling confident about scarlet fever, especially if you're prepping for the MSRA. We're going to cover, well, everything.
The works.
What it is, the causes, who's more at risk, how it actually affects the body, what else it might look like.
The differentials, yeah.
Who gets it, the signs, the symptoms, diagnosis, treatment, what recovery looks like, and importantly, the complications.
And we've got some memory aids lined up too.
We do. Memory tricks, example questions, all to help it stick. Right then, let's dive in. First off, what exactly is scarlet fever?
Okay, so simply put, scarlet fever is an infectious disease. It's caused by bacteria, specifically Streptococcus pyogenes. And the real giveaway sign, it's this very characteristic rash.
Okay.
Now, it mainly affects children, that's true, but it's worth remembering really that anyone can actually catch it.
Right.
The core things you see are that rash, it's what we call maculopapular, sort of red and bumpy, plus tonsillitis, so a sore throat, a fever, and often a headache too.
Okay.
The good news, though, is that it's typically quite mild, and it responds really well to antibiotics. Getting that treatment started quickly is really the key thing for preventing any later problems.
Got it. So that's the what. Now the why. What's the cause, the etiology? How does it get going?
So the root cause is an infection with Group A Streptococcus bacteria.
Oh.
But what's really interesting and key to understand is that the classic scarlet fever symptoms aren't directly caused by the bacteria just sitting there.
Oh.
No, it's actually toxins that these bacteria produce. They're called erythrogenic toxins. Erythro meaning red.
Ah, makes sense. The rash.
Exactly. These toxins cause the inflammation, the rash, the fever, all those characteristic signs. And it spreads pretty easily. We're talking respiratory droplets,
Yeah.
Coughs, sneezes.
The usual suspects.
Yep. And also direct contact with things that are contaminated. You can imagine with kids sharing toys, touching surfaces in school or nursery.
Yeah.
It can pass around quite readily.
Yeah, you can see how that happens. So thinking about who gets it,
Mm.
are there specific risk factors, things we should keep in mind, especially for, say, MSRA revision?
Definitely. The most common age group, hands down, is children between 5 and 15 years old. But like I said, and this is important for exams, it's not only them. Anyone who hasn't already developed immunity to that particular strain of strep can get it. Close contact is a really big factor.
Makes sense.
That's why you see outbreaks in crowded places, schools, daycare centers, just more chance of exposure. And of course, if you haven't met this type of strep before, your body's not ready for it, so you're more susceptible. And finally, basic hygiene. Hand washing really does make a difference in stopping the spread.
Okay, that's clear. So bacteria, toxins, immune response. Let's zoom in a bit. The pathophysiology, what's actually happening inside the body when someone gets scarlet fever.
Right. So as we said, it starts with Group A Strep, releasing those erythrogenic toxins. Think of them as the primary troublemakers. They trigger inflammation,
Okay.
and that inflammation leads directly to the rash, the fever, and other symptoms. So the bacteria usually infect the throat or maybe the skin, then they pump out these toxins into the bloodstream.
Ah, so they travel around.
Exactly. That's how it becomes systemic, causing the widespread effects like the rash pretty much everywhere. And it's not just the toxins, our own immune system's reaction to the infection and the toxins also shapes how the illness plays out. That's another factor in the mix.
Right. The body fighting back contributes to the picture too. Okay. So we have this collection of signs and symptoms, but crucially for revision, what else could it be? What conditions might look similar? What's the differential diagnosis?
Yeah, that's super important for MSRA prep. When you see that classic presentation, rash and fever, especially in a child, you need to think broader. It helps to group things.
Okay.
First thing, viral examptoms, rashes caused by viruses. The big ones to keep in mind for exams are definitely measles, rubella, and also infectious mononucleosis mono.
Right, the common viruses.
Then there's some other really important ones, though maybe less common, that you must consider. Things like Kawasaki disease.
Ah, yes, the inflammatory one.
Exactly. And toxic shock syndrome, that's a serious bacterial toxin thing. And don't forget, drug reactions, always ask about recent medications.
Good point.
And then there's a wider list, for completeness. Erythema infectosum, or fifth disease, roseola, other sort of non-specific viruses, erythema multiforme, even things like staphylococcal scalded skin syndrome, severe sunburn, plant allergies. The list does go on.
Wow, quite a range. Any tips for remembering those differentials?
Well, a simple approach is see rash and fever. First think common viruses, measles, rubella, mono. Then quickly consider the serious stuff, Kawasaki, TSS. And always ask about drugs. That covers the most critical bases quickly.
That's a helpful strategy. Okay, let's pan out again. Epidemiology. For revision purposes, when and where does scarlet fever tend to pop up? Any trends we should be aware of?
Yeah, for your MSRA, definitely remember the seasonality. Scarlet fever often sees these sort of peaks, typically in late winter and into the spring.
Okay.
Historically, it was a much bigger deal, causing major epidemics back in the day. It's less common now, obviously, but it hasn't vanished. In the UK, for instance, you might expect maybe 3,000 to 4,000 cases a year.
Roughly, and specific numbers.
There was data from England, 2014-15, showing about 10.7 cases per 100,000 people. So it's around.
Right.
And as we've touched on, it's mostly hitting children under 10. You definitely see more cases in places where people are in close quarters, schools, nurseries again.
And why less common in adults?
Mostly immunity. Over time, most adults have encountered Group A Strep in some form and built up defenses. So, key epipoints for MSRA. Winter-spring peak, mostly kids under 10, and association with close contact settings.
Great, that's good context. Now, the really practical bit. What does it actually look like, the clinical presentation? For revision, what are the absolute key features of scarlet fever we need to recognize?
Okay, this is core knowledge for your MSRA.
Yeah.
There's some really classic signs. It often kicks off with a really sore throat. Properly painful, red, inflamed, hurts to swallow. Usually comes with a high fever, often spiking above 38 degrees Celsius. Then the really distinctive things. The strawberry tongue.
Yes, the tongue.
Remember, it can start off white-coated with red dots.
Right.
The white strawberry tongue, before becoming bright red and bumpy.
Right.
The red strawberry tongue.
Yeah.
And, of course, the rash.
The defining feature.
Exactly. Fine, feels like sandpaper to touch, usually starts around the neck and chest, then spreads downwards and outwards. And don't forget Pathophysiology lines.
What are those again?
They're these brighter red lines or streaks you see right in the skin, creases like armpits, groin area. Very helpful sign.
Right.
You'll also likely find swollen, tender tonsils and lymph nodes in the neck. It's most common, as we said, in that 4 to 8-year-old range. Spreads via droplets, sometimes direct contact with strep skin sores, or even from people carrying the bacteria without symptoms.
Right.
Often there's a sort of lead-up, the prodrome,
Yeah.
fever, sore throat, those swollen neck glands, maybe headache, feeling sick, sometimes vomiting, that early strawberry tongue. Then the rash usually follows a day or two later.
And the rash itself.
It's maculopapular, small, flat spots and raised bumps. Widespread, but characteristically, it tends to spare the palms of the hands and soles of the feet. And you often see paleness around the mouth. We call that circumoral pallor.
Right. The sandpaper feel is key, too.
Absolutely key. Remember that texture. It generally fades after about a week, but then you often get peeling skin desquamation, especially on the fingertips, toes, in the armpits and groin, even the ears.
Anything else to look for?
You might notice the heart rate is up a bit with the fever, tachycardia, and sometimes tiny red spots like little bleeds on the roof of the mouth, petechia on the palate.
That's a very detailed picture. You mentioned memory aids earlier. Sounds like we need one for all this, especially for MSRA prep. Got a mnemonic?
I do. It's a good one for MSRA revision. Just think. Strawberry.
Strawberry. Okay, break it down for us.
Right. S is for sore throat. T is for texture, that sandpaper rash. R is for red lines, increases Pathophysiology lines. A is for around the mouth is pale circumoral pallor. W is for widespread rash. It goes everywhere. Well, almost. B is for bright red tongue, the strawberry tongue itself. E is for enlarged lymph nodes in the neck. R is for running a high fever. And the final R, let's make that rash peeling afterwards. And Y, well, you feel yucky.
Strawberry. That's brilliant. Really visual, helps pull it all together for revision. Okay, so someone comes in, they look like they fit the strawberry picture. What next? How do we confirm it? What investigations are crucial for the MSRA?
For your MSRA, the main goal is confirming that Group A Strep is involved. The absolute gold standard is the throat swab. You get a sample from the back of the throat, send it off to the lab for culture.
Standard procedure.
Yep. There's also the rapid antigen detection test. You can sometimes do that chairside or in clinic. It's much quicker, gives you an answer in minutes, but it can be less sensitive, meaning it might miss some infections.
So a negative rapid test doesn't completely rule it out.
Exactly. If the suspicion is high, you might still do a culture or treat based on the clinical picture. Then there are streptococcal antibody tests, like ASO titers. These aren't usually for initial diagnosis, more for confirming a recent strep infection if you suspect complications later on, like kidney problems.
Okay.
And a full blood count, FBC. It might show raised lymphocytes, which can happen, but it's not specific. The main thing to stress for MSRA is that diagnosis is largely clinical, based on those classic signs and symptoms.
Right.
And because you want to prevent complications, treatment with antibiotics is often started right away, even before you get the lab results back.
Makes total sense. Act fast. So let's talk treatment management. For MSRA revision, what's the standard approach, particularly thinking about UK guidelines?
Okay, UK management for your MSRA. Number 1, antibiotics. Absolutely key. The first-line choice is usually oral penicillin V, and it's crucial, a full 10-day course.
10 days, right. Not stopping early.
Absolutely not. Got to complete the course to properly zap the bacteria and prevent things like rheumatic fever. If someone's allergic to penicillin, then azithromycin is a common alternative, usually for a shorter course, like 5 days.
Okay. And for the symptoms, the fever, the sore throat.
Yeah, symptom relief. Paracetamol is your friend for fever and pain. Simple, effective. Just remember the usual advice, no aspirin for under 16s because of the risk of Ray's syndrome. Ibuprofen is an alternative if needed and suitable.
Good point. What about keeping others safe? Isolation?
Yes, isolation is important to stop it spreading. The usual guidance is that children can go back to school or nursery 24 hours after starting antibiotics, provided they're feeling well enough.
24 hours. Got it.
Also, remember for public health reasons, scarlet fever is a notifiable disease in the UK. You have to report it. And keep an eye out for potential complications. Things like ear infections, otitis media, or rarer but serious things like rheumatic fever, pneumonia, kidney issues. Be vigilant. Sometimes if a child gets recurrent tonsillitis or strep throat, an ENT referral might be considered down the line.
Right.
And finally, don't forget basic supportive care, plenty of rest, lots of fluids, helps the body recover.
That's a clear plan. So, assuming prompt diagnosis, correct treatment, what's the outlook? What's the prognosis we should know for MSRA?
For your MSRA, the key message on prognosis is generally excellent. With early diagnosis and the right antibiotics, it's usually a mild illness.
That's reassuring.
It is. Serious problems, significant morbidity, that's much more likely if it's left untreated, and those complications we talked about get a chance to develop. But antibiotics are very effective. They control the infection, prevent the complications.
How quickly do people get better?
Most people feel much better within a few days and fully recover within about a week. The rash might take a little longer to fade completely, and the skin peeling can last a bit too. But the main takeaway for revision is, treat it promptly, prognosis is great. Untreated, that's when you run the risk, albeit rare these days, of serious issues like rheumatic fever or kidney damage. Really hammers home the importance of treatment.
Definitely. It highlights why spotting it is so vital. Let's just circle back to those complications. For the MSRA, can we detail the main ones again, the things we're trying to prevent?
Sure. The big one, the one historically feared and still the main reason for thorough treatment, is rheumatic fever.
The heart, joints, brain thing.
Exactly. A serious inflammatory response.
Yeah.
Then there's potential kidney damage. Post-streptococcal glomerulonephritis can cause kidney inflammation. Ear infections, otitis media, are actually relatively common complications.
Okay.
Less common, but possible, are things like abscess formation, often around the tonsils, Kunze, pneumonia can occur sometimes, and very rarely, but life-threateningly, toxic shock syndrome linked to the strep toxins. You should also be aware, for MSRA purposes, of other rare but severe invasive complications, things like bacteria getting into the blood, bacteremia, meningitis, or even necrotizing fasciitis, the flesh-eating bug. Very rare but devastating.
Goodness.
And infection can spread locally too. Numbers-wise, the risk of rheumatic fever after untreated strep throat is maybe around 0.3%. Post-strep kidney issues are similarly low risk. But it's worth noting that having chickenpox recently seems to increase the risk of some complications.
Interesting point.
And sometimes you see minor lingering things like temporary nail changes or a bit of hair shedding a month or two later.
That's a sobering list of possibilities, even if rare. Right, let's pull it all together then. For everyone listening, especially those revising for MSRA, what are the absolute must-know takeaways from this deep dive on scarlet fever?
Okay, key points for your MSRA. Scarlet fever, Group A Strep infection. Hallmark is the sandpaper rash and strawberry tongue. It's treatable with antibiotics, usually penicillin, 10 days. Early treatment leads to excellent prognosis, usually mild.
Yeah.
Crucially, prompt treatment prevents serious complications like rheumatic fever. So recognize the signs, remember strawberry, get medical advice quickly, and ensure the full antibiotic course is taken.
Perfect summary. And just a reminder, if you want to cement this knowledge and tackle more questions for your MSRA, definitely check out passthemsra.com.
And freemsra.com too. Lots of great free resources there.
Absolutely. Passthemsra.com and freemsra.com.
Okay, to finish up, a little something for you to think about. We know childhood illnesses are common, things pop up all the time. So personally, what strategies do you find work best for keeping the key features and the management of all these different conditions straight in your head? How do you stay on top of it all? Something to mull over. Thanks for joining us on the deep dive.